Right.
Hi everyone, welcome to session 4. We're looking at community health and wellbeing. We're now on duty 2. So duty 2 looks at the community and building up the resilience within that community for mental health and wellbeing practitioners. What we'll do, we'll dive straight into the online material. We'll explain the material that's there. We'll then look at the assessments for duty knowledge. And we'll look at some assessment tools and processes. So reflecting on what we covered last week, which was looking at the toolkits that we've created. So we've got our social prescribing toolkit, we've done our strategy toolkits for emotional intelligence, emotional awareness, resilience, etc. So we're going to be leaning on a lot of that we've covered as well. So just looking at this then, duty 2 looks at helping communities to build local resilience and identifying strengths. So if we break that down, looking at the communities are the people within our demographics, within the area that we're in. And those communities are going to be our religious and spiritual, it could be schools, it could be our primary and secondary healthcare, and then it's our communities and groups. So really understanding who's within our community. And that's important when we look at community health and wellbeing, because we need to work alongside the Localism Act to making sure that we're providing local care for local people. And we understand the needs of our local community. And that does differ for different areas of London. Furthermore, that differs for demographic areas of the country. So we have a very different culture in the south to up in the north, to the northeast and northwest. So just understanding some of those differences. Those local resiliences then looks at how communities come together and to support. So what we tend to find is along seaside coastal lines, there's a higher level of deprivation. And in higher areas of deprivation, you normally have higher levels of unemployment, social and economical problems. If we think about the psychosocial model, we have deterioration of the health and well-being, so diabetes, high levels of cholesterol, and then substance misuse, alcohol, smoking, etc. So thinking about some of that, it gives you an idea of some of the problems that you're going to face within those areas. If we then look at the strengths within the areas, so normally what happens, funding goes into an area to build an area up. So if we've got an area of higher unemployment, generally what should happen is the council will go, right, you're going to get more money put in there to help with unemployment. And that's important because employment is part of that social thing. So not over-medicalising social problems, but being able to have solutions. Or alternatively, if there's a high level of substance misuse, you tend to find that there's a lot of substance misuse services. So where I'm from in the southeast, down in Hastings, we've got a lot of services to support drugs and alcohol services. That's things around Change, Grow, Live. There's the Oasis project. There's lots of different projects that can help with those particular problems. So that's a real strength to the area. And again, understanding the resources within your area is obviously key for social prescribing. So going back to that social prescribing piece that we did gives you an idea. So that's a breakdown of the duty. If we now look at the knowledge and what we're going to learn, so within today's session, we're looking at case 6, 7, 8, 9, and 10. So we're looking at the most up-to-date evidence-based information for informing and managing community development approaches to promoting health and wellbeing. We're looking at building those partnerships with individual groups within our communities, because our role is about networking and bringing that all together. We can look at national guidance, and we'll look at how national guidance shapes some of the decisions we're going to make on interventions to promote health and wellbeing. We need to recognise the non-statutory requirements of the voluntary groups that help us. We can look at some of the risks associated to those. So again, I know down the road, we've got a really lovely charity that's a family charity. and they also do bereavement services for children that have lost family members, etc. So just knowing what's in those areas is important. And again, from a risk assessment point, we have a high prevalence of suicidal ideation and self-harm in the area. So knowing those charities and organisations that manage that is key. And then finally, we look at the concepts and theories that underpin the strengths and the asset-based approaches. So quite a lot to cover in this session. The next session, then, we look at the skills and we start to look at how we actually address some of those problems. So thinking about then the duties, we've got our PowerPoint presentation there. So we can look at our community resilience building. Part of that looks at the projects and goals to identify resilience within the area. It looks at strengthening the capabilities and the resources, and it looks at those two-pronged approaches of health and well-being. So thinking about how we truly capture health and how we then support well-being. Health, primary care, physical health conditions. So as a community health and wellbeing practitioner, you should have a fundamental understanding of common health problems: diabetes, cholesterol, musculoskeletal, pain management is on the rise. Those health conditions, things such as COPD, asthma, and then the mental well-being, so things of common mental health such as anxiety, depression, suicidal ideation. So if we can work with organisations and communities to meet the needs of our community, we're able to get the message out. So we're able to get that social prescribing piece out, and we're able to provide networkings. So we're able to upskill areas, create places of safety, have more mental health first aiders, have places where people can go to within the community that shows this whole networking to support this. So building resilience in communities and uncovering strengths and resources for health and well-being. Within this, then, we're going to look at how we build communities, the resilience, looking at strengths, capacity and resources, assessing community needs, partnership working, development planning, celebrating success, and then on the right-hand side, all about building resilience. So thinking about building resilience as a coping strategy, as a coping skill. So if we go back to our strategies, building resilience is one of the strategies that you could learn to help. And again, when we see things on here, we've got things like building resilience in the face of natural disaster. And sadly, in the last year, we've seen a lot of natural disasters. We've seen earthquakes in Turkey, earthquakes in Morocco, as well as then the war conflicts within Russia and Ukraine, and now over in Israel and the Palestinians. So it's important to understand how we can support those natural disasters, and we'll talk about some of the strategies around emergency planning for that. We'll then summarise this and look at some of the reference tools. So building resilience in communities is crucial for ensuring the health and safety and well-being of individuals. So having this strong network is a great way to understand how it all comes together like a jigsaw. So how your police service works, how the fire service works, how the ambulance service works. And as an individual working within health and well-being, you need to understand those pathways of referral. So understand what each person's role and responsibility is within your community. Equally, we don't want to medicalise every single problem. Sometimes they're social-based problems. So thinking about social prescribing, thinking about using your local communities to help problem solve. And that might be charities and organisations such as CAB, Managing Debt Advice, or ACAS for employment services, etc. So whether you're facing a natural disaster or an economic challenge or social issues, building resilience allows communities to adapt and to thrive and to face adversity. Understanding these processes helps create stronger communities and brighter futures for all. So you, as a community health and wellbeing practitioner, need to build that community resilience, understanding who's in your networks, and kind of produce some kind of document, really, so you could use that as a point of referral. So what is community resilience? Well, community resilience refers to the ability of a community to adapt and recover from an adverse event. Now, when we think about resilience, we all have resilience. It's all within us. So before COVID came along, none of us really thought we could manage a lockdown. We didn't realise what mass death would look like across the globe, but we've now survived it. Meaning, if we had to go through it again, we've built some resilience up. We're kind of ready for it. If you think about natural disasters, so what's happened in Turkey, Morocco, and wars, their level of resilience, these people that have gone through this, their resilience is going to be extraordinarily high because they've had no choice. It's the fight, flight, freeze response. They've stood, they've fought, they're dealing with it. And that's because the body does this auto response thing, and therefore their resilience comes a lot higher. So it's called emotional numbing in some ways. However, if you've led a very sheltered life and you've never really experienced much and you've been sheltered from the world, your level of resilience is going to be much lower. So as a community that's never faced a lot of adversities, maybe you're in a wealthy area, you've not seen much adversity, when something negative happens, it has this ripple effect and it affects everybody in the community. So trying to build community resilience actually works really well because you're preparing them for an emergency of some kind. So maybe flash floods, fires, disasters, a bit of emergency planning going on. But you're also looking at how to bring people together and to rely on people's strengths and ability to plan and to face adversity. And it really is about community resilience, is about having a better understanding to manage that shock and the stresses that have that negative impact on events, on physical, mental health and social problems. So thinking about your community resilience, if you're in a wealthy area, what does that look like? But if you're in a hard to reach area, what does your community resilience look like? Identifying strengths, capacity and resources. So knowing what's in your area, knowing the resources that you can lean on. So knowing spaces is really useful. So if you are a community health and wellbeing practitioner, let's say you're at work, and let's say, for example, something happens at work, let's say your building floods or something. Knowing that you've got a church hall, knowing that you've got a charity organisation like the Red Cross or St John's on the road that maybe have halls that you could use. You could use the community organisations to lean on to help in adversity. And what we've seen through community support is that people do pull together. So don't be afraid if you're a care organisation or a charity and you need support to help network or something. Lean on the charities organisations there and see how you can support them, but see how they can support you. Because ultimately, we should all be planning for those times when there may be an adverse problem where it's a natural disaster, health disaster or something. So at least we're prepared, and the phrase is, better prepared and all of that stuff. So just think about the resources in the area, think about how you can network with those community and charity organisations, and think about the strengths within your organisation. And I would say when we went through COVID, we saw a real champion strength within our communities. We had people giving us money, we had people giving us food banks, we had people giving us clothes. We were able to share those resources across the community. So just thinking about how you can network and be involved within your community is really important. So assessing community needs really is a crucial step to building community resilience. You need to understand who's in your community. You need to understand the resources that you need for that community. And then you can start to look at the gaps that appear. And it's a bit like when a town's being built. So for every town that's being built, they need to see how many GPs and dentists and schools need to be built. So same thing around resilience for planning for physical health and mental health. You'll need to do some kind of gap analysis. So looking at the things that you might need. So if you're living in London, for example, you might have a multicultural faith around you. So you might have Muslims, Christians, Catholics, Jewish. How will you coordinate and manage all of that when dealing with health and well-being? Where could you go to get that support to meet those health needs and those mental health needs? And equally, when we think about building resilience, some of that requires psychoeducation. And psychoeducation is upskilling the community to understand the things around stigma and acceptance and changing things. And to change things, sometimes you have to go through your faith leaders and spiritual groups, because they're able to disseminate that information out to the community a bit better. That then rolls into engaging with the community. So engaging with the community is a crucial aspect of building resilience. By involving the community and their members, you end up with this ownership. And the more people involved, the more resilience you can have. So let's say, for example, we've got a national strategy for people to know their blood pressure scores. The government did a national campaign, Know Your Score, that's physical health. We know that if we know our blood pressure score, we have a chance of reducing hypertension, we reduce our chance of strokes and heart attacks. Equally, things around CPR. So schools the other day did this massive campaign. I think it was 8,000 children were learning CPR and teddy bears. Great, so that's communities coming together to learn CPR. Who are your community responders? Where are they? Where's the equipment? Where's your DFibs in the area? Do you have expertise locally? What happens if you had an incident or accident? What happens if you had a situation where you were trying to support somebody who was maybe suicidal, self-harm, or in psychosis? Who could you lean on? Where could you go? So just understanding this is great. And equally, having a neighbourhood programme allows you to then do social prescribing really well, because then you understand what the community is doing. And every community has community boards, so whether that's in the co-op, whether that's in supermarkets, whether that's in your now closed down libraries or sports centres, they have groups and activities, so like Slimming Worlds and lots of things. You understanding all this allows you to then socially prescribe or talk to people. So if somebody's saying to you, look, I'm bored, I'm on my own, I've got social deprivation, you could say, well, have you down the road in this church, or they do this group, or down there they do that group. And it's okay saying we have technology. However, a lot of these small groups can't afford to advertise online, so therefore they don't get seen when we do searches. So bear in mind that still sometimes doing a bit of legwork, talking to your local community, understanding your networks is a crucial way to building up engagement. And then be part of that solution. So if you've learned a new skill, such as, I don't know, how to manage choking or deal with CPR, don't be afraid to contribute back to your community, because that allows then building partnerships. And building partnerships is this give and take approach. And it's what we like to call in the industry the win-win approach. What works well for us needs to work well for them. And if we can do win-win approaches, we end up with better stakeholding. We end up with better, stronger communities, because it's not all take or all giving. Remember that there's a lot of organisations out there that are led by charities, organisations, maybe they receive lottery funding, or they're not-for-profit organisations. And they're the kind of organisations we need to get behind to support, because if they're not-for-profit, they are designed to, all of the money is invested back into the community. So knowing your organisations in the area that are not-for-profit may give you an idea of points of referral, knowing that resources are going back. And we talk about that because there's partnerships around things such as Counselling Plus. Now, Counselling Plus is a not-for-profit organisation. It works as a charity and an organisation. You pay a minimum fee if you're on benefits. It allows trainee therapists to train there. So it's a win-win situation. People can come in and upskill. People can use the service that can't afford it. But again, locally, we need to raise the awareness about those organisations to keep them central, because they are absolutely fundamental to local resilience. So part of your apprenticeship is to develop this plan to understand community resilience, to understand how and what we have, to really fundamentally understand the resources. And a good plan should involve all of the stakeholders. And from that plan, you should be able to identify your strengths as a community, what your strengths are, and the resources you have. And again, if you're networking, maybe your borough in town or your borough in council, they have strengths in other areas. And that's because of this funding that we talked about earlier about deprivation of funding being used. So maybe you've got all the funding for drugs and alcohol, but they've got all the funding for employability. So it might be the case on sharing some of those resources to try and better meet your community needs, especially for points of referral. So when you're trying to refer someone to get support, just think about that. So implementing the plan looks at our plan, do, review approach. So once you've got your plan, you can look at building community resilience, you can look at the strengths, you can look at the resources, and you can do some networking yourself. So if in your town you've got a football club or you've got scouts and guides and all of this stuff, use what you have and take it to them and try to get some buy-in from them as well. Because anywhere where you can push health promotions, anywhere where you can push mental health promotions, is about reducing the stigma and raising awareness. And that's half of our battle. If we can raise awareness and reduce stigma as a community health and wellbeing practitioner, that's half your job done. Because the more knowledge the community has, the less likely they are to lean on you. And then the more you're able there to kind of be a bit more effective, because you're not just repeating yourself over and over again. I remember when I sat in primary healthcare talking to people, I was saying the same thing constantly over and over again. We're actually, had this information been freely available, people wouldn't have been coming to primary healthcare to get this information. So think about how you can use social prescribing strategies and those tools to reduce the reliance of primary and secondary healthcare. And then finally, think about how you're going to monitor the effectiveness of your strategies. So once you've looked at your community strategies, how many referrals are you making? What does that impact look like? And how does that look? And obviously, there's the old acronym using SMART targets, specific, measurable, achievable, relevant, and time-bound or realistic. Think about how you're going to track, think about what that looks like, and then think about the quality improvement program that you're going to do off the back of that. And then finally, try and collate some of that data and celebrate success at the end of it. And what I mean by that is, let's say you started off with a plan to reduce everyone's blood pressure score. So I've targeted 100 people, we've done 100 blood pressures, we've given them advice and guidance about keeping active. So we've got active Hastings, we've done diets and nutrition. So I did a referral to the dietitians. We did statins and things to the GP. When we reassessed 100 people, 95% of them, their blood pressure was within normal range. And celebrate that success, because the more success we celebrate, the more we see it works, the more buy-in you're going to have from the community, and the more preventative work we can do to manage this. So this works really well in a domiciliary care setting when we've got people who are piling up comorbidity. So they're piling up weight, they're piling up their cholesterol, they're piling up their blood pressure, they're increasing their risks for a stroke or a heart attack, substance misuse, alcohol. You know, if we started to work in a much more preventative way, then hopefully we can stop the reliance on all of these continuing healthcare assessments and additional funding, because we can reduce the need in one hand and then push better outcomes in the other. So your role as the community health and wellbeing practitioner is to kind of benchmark your project, drive it through, see if you can reduce it, and then obviously celebrate the success on the other side. Because at any outcome that results in the use of primary or secondary healthcare has to be good for our NHS. So building resilience in more vulnerable communities is definitely going to be a challenge, because again, people feel that there's a problem around funding being unfairly distributed. In areas of deprivation and poverty, you've probably got high levels of substance misuse, so therefore there's going to be a lot more work around understanding why people are using substances, looking at how we manage that. Generally, in areas of low income, you end up with a thing called food deserts. And what food deserts are, it's where you've not really got access to supermarkets, but within your kind of local area, it's all takeaway food. So again, if you've got that, then that's a barrier straight away. Lots of wine shops, lots of alcohol shops, lots of things pushing this unhealthier lifestyle. So it's going to be even harder to push health promotions and build resilience up within those areas. Now, ultimately, I'm not at all suggesting you go out there and start lecturing people. In fact, the evidence suggests if you do that, people just switch off. What we need to be doing is providing good quality information for people to make informed choices, but in an informal way. So having it in discussions, having it on notice boards so people can see, and maybe going to schools and colleges and talking to other people about kind of health promotion other than just you pushing it. There are obviously health inequalities there, and those health inequalities can come around an array of things, such as maybe refugees, maybe to a second or third generations of unemployment, or again things about around that food desert that I was talking about. But again, all of those things around health inequalities can be fixed. I was a part of a project last year called the Universal Healthcare Project, and it was all about monitoring health inequalities. And what was interesting off the back of that, for every inequality that was identified, there were several solutions. It's just that nobody was pulling it together. So when we think about the inequalities to refugees, actually there are charities there that manage refugees. There is funding there from the council to fund health inequalities for refugees, because again, it's important that people from the refugee status are getting vaccinated, they do get their medicines, because if they don't and they have disease or infections, then that actually causes an outbreak and causes further problems which could be avoidable. So we want to avoid inequalities around accessing health. Again, your travelling community, so looking at your travelling community, how do we narrow that? And what we found was during COVID, we were going to people, so people that couldn't access services, we were going to them. So thinking about your role within your organisation, how can you ensure that inequalities or accessing those health inequalities are going to be sorted? And let's say you're in a residential home or a nursing home or domiciliary, you're going to say to me, oh, but Steve, we don't have inequalities. You absolutely do have inequalities. So I'll give you a couple of examples. So one is you ring up the doctor and say, doctor, I need you to see Mary. She's not very well today. And the doctor says, oh, I'll add you to the ward round. It's next week. Now, is that or is that not a health inequality? Because Mary's in a care home, because Mary's over a certain age, the doctor's gone, I'll add you to my list. Now, if that were anybody else with that health emergency, they'd have seen somebody or spoken to somebody that day. But because it's an elderly person, they get triaged to a ward round. So that's a health inequality. Other health inequalities can exist around denture care. Can you get an NHS dentist at the moment? No, you can't. That's a health inequality. So if it's only private patients, not funded patients, we need to think about, well, how can we bridge that? So even within your services, there are health inequalities happening. And if you can't spot them, I'd be very worried. So what I want you to do is think about what they might be and then put some strategies together. And that may be then engaging with communities, that may be working with diverse communities and building that resilience to kind of bring everyone together. Equally, if you're in the southeast of England or the northeast, when you've got lots of rural areas, thinking about the health inequalities for rural areas. So in rural areas, you've got lack of access to health, wellbeing services and mental health professionals because they normally go to condensed areas. Meaning, again, another health inequality might be just based on your postcode. So how can we access good quality healthcare to those rural areas? And that might be we use online resources to manage that. So thinking about how we can access that. And again, that's for your family, mental health, etc. Looking at building resilience in urban communities, again, thinking about there's the lack of green space, population density, you've got your quality of air, but that's okay because if you're in London now, you've got the ULEZ, so that's going to create you lots of fresh air. You may or may not want to use that as an inequality or a quality thing. That could be a decent essay later on in this topic. But looking at the fact that in urban areas, for example, if you looked at the underground is twice as polluted as above land. So we need to look at how do we build the resilience around that? What can we do to provide fresh air and fresh produce and green space? Looking at how we build it in schools. So again, looking at the people that you're looking after, looking at their common health problems, looking at their common mental health problems, you going to the younger generation and providing information, advice and guidance to them is key, because what we want to do is change or break the chain. So if we've got lots of substance misuse, for example, in Generation X, hopefully Generation C, which is the younger one, I think I've got that the right way around, they will be able to break that chain so they don't then have an aging population with a substance misuse problem. And we can see that that's changing just with smoking. So if we look at smoking cessation, the government's pushed up the cost of smoking. They've stigmatized smoking to make it almost an evil, bad thing. And now we're looking to go smoke-free. But if we look at how health has changed, there was a great study online that I saw the other day that if we look at our younger generation now, if we take a picture of an 18-year-old now and we take a picture of an 18-year-old back 30 years, 30 years ago, that 18-year-old was looking 22, 25. But because we have better health promotion, because we have less people smoking, they're keeping their youth for longer. And that kind of makes sense because we're not putting the poisons and the toxicity in the body, and we're better equipped to manage that. So even just bringing that education into schools will start to enable some of that resilience and training around building that. Again, building resilience in your workplace is going to be looking at your culture, your values, your missions and statements. Better workplaces have increased productivity and job satisfaction. I think it's Norway or Denmark, which is one of the happiest places in the world to work. They've just gone to a 4-day working week. They're having higher productivity, better outcomes, and a reduction of mental health. So thinking of the strategies in which we can bring into the workplace is key. Promoting work-life balance, promoting health promotions, and promoting mental health and coping skills as well will be key to supporting that. Looking at building resilience in healthcare settings, so again, similar things. Ensuring that we have a culture of supervision, ensuring that we have a culture of reflective practice, looking at how we can come together, looking at how we can cope with natural disasters and pandemics. None of us want to face a national disaster unprepared, and it would be quite arrogant to be working in healthcare to think we're not going to have another pandemic or we're not going to have a national disaster, especially with the political stage at the moment. So it's really important that we have discussions at work, that we talk about healthcare planning. What would happen if we had this? What do our contingency plans look like? And what's our role as health and social care staff through the ranks in supporting this? And how would we get to work? And what would that look like? And how can we prepare for this? So emergency planning, contingency planning, it is a CQC outcome. And it's also useful for us so we don't end up going through the same stress that we went through with COVID. Building resilience in emergency management. So again, for people that have been working with emergency services, our resilience builds one person at a time or one emergency at a time. What then tends to happen is the more disasters we go through, the more emergencies we face, the more resilient we become. Eventually, we get accused of being quite cold-hearted, and that's not the case at all. We've just become resilient. We've just become emotionally resilient to this. So just understanding that even people who have high resilience still have feelings. They've just learned to deal with the incident at hand, and therefore should have some mental health support afterwards. Looking at building resilience around climate change. So in your apprenticeships, and in all the apprenticeships now, they are bringing in a 2050 agenda. I don't know whether that's in or out under this new government, under Conservatives at the moment. I think it was there. Then I think our current Prime Minister was going wobble, wobble, wobble. But anyway, at the moment, our training targets on there, so something around 2050, we should be looking at a much more green workplace environment. Now, part of what we are responsible for, community health and wellbeing practitioners, is how can we bring that into our workplace? So what can we do to help promote a cleaner environment, which is obviously better for everyone? We've already talked about national disasters. One of the things that I will say about national disasters, there's new evidence coming out of NICE guidelines, the National Institute of Care of Excellence guidelines, that in a national disaster, the therapy that should be used straight after the disaster is EMDR, so eye movement desensitization reprogramming. And that's because the evidence now suggests the sooner we can process that trauma, we process the trauma, we move it to the long-term memory, the less likely it is that it's going to affect them. And we know this because it's now been piloted in national disaster areas. So they piloted EMDR in Turkey after the earthquake and in Morocco, and lots of EMDR therapists went out. They managed the therapy with these people. They also did group EMDR therapy, so lots of group therapy there, processing trauma to help it move forward and help people to gain their resilience back and their coping skills. And it's important that people bounce back quickly after a national disaster, because again, the quicker we bounce back, the more resilient we become. So just thinking about how we can be prepared for that. So your role as a community health and wellbeing practitioner there might be to look at some of those therapy techniques, think about how they can be used, and have that information, advice and guidance ready to hand if that were the case. Or again, you could learn some basic safe space techniques throughout the course. If you go to the mental health nurse or you go to my YouTube channel, you will see that I teach you how to do some of those therapy techniques. And you can have some of those therapy techniques ready for helping people in national disasters or in areas of quite high intensity feelings. So things like safe space, things like meditations, things like calming exercises would be great and a great skill for you to learn. Building resilience in the face of economic challenges. So again, thinking about everything that we're doing, the reason this apprenticeship has come out is because of economic challenges, because what we're doing, we're pushing mental health and physical health together, and we're saying we need to take a much more holistic approach to managing all of this. So think about how you can work on a much more holistic level to manage resilience. And again, same for building social challenges. So looking at what's those social problems around housing, around debt. We know housing debt causes anxiety, we know it causes depression, we know it causes suicidal ideation. So if you go back to your toolbox, having the answers for this is going to really help a lot of people. And you might say, well, how's that going to help me in a care home setting, Steve? Well, if you've got family members unable to pay for loved ones' care and they're thinking they have to sell their houses, understanding the Housing Act and the Social Care Act is really important. understanding debt management and debt advice is really important. There's lots of organisations out there. And ultimately, there is no social problem that can't be overcome. So having that belief, understanding your referral points can really make a difference to somebody, especially for somebody who's ruminating, who's spiraling because of that fear and worry around debt and well-being. So in conclusion, building a community that has a stronger resilience, identify strengths and capacities, understanding your resources, preparing and being equipped for those challenges, build stronger resilience in communities. Being prepared for emergencies or disasters is about addressing the health inequalities, engaging with the community, building those resilience in schools and workplaces and health settings, and facing those economic and social challenges. By working together, you'll be able to identify the strengths and the resources you need to build a much stronger, more resilient community. There's some referencing on there for you to have a look at if you want to. And that's the end of the presentation. So now let's quickly flick through the other slides. So case 6 looks at the most up-to-date evidence base for creating inclusive practices. So here we're looking at different approaches. We're looking at social dimensions of health. We're looking at strength-based practices. We're looking at those cultural competencies. We're looking at technology and data, and then we're looking at the evaluation there and continual learning. Case 7 looks at the importance of building partnerships, so work with individuals and groups. K8 looks at those national guidelines, so recruitment, training, development rights, and the NICE guidelines. K10 looks at those concepts and theories of a strength-based approach. And then finally, 9, we look at those groups, those voluntary groups and those statutory groups as well. So all you now need to do is go online, do this test, and that's you all done for this week. I'm sure you'll fly through that without any problems. And next week, we're going to look at those skills. So thanks for watching. If you've got any questions, by all means, pop them in the post or let me know. And when I mean post, I mean the inbox. Don't post me because that'd be weird. Pop it in there and we'll see you next week. So thanks for watching and I'll see you all next week. Take care. Bye for now.